never done telemedicine before to be onboarded on an easy-to-use telemedicine platform. And that also, of course, includes screening and following up. So it's, certainly not a new technology, but the adoption is quite amazing. And, people are forced a bit into adopting. And I say the third project I just want to highlight, it's actually in the US, working with senior patients. As you know, they are the most vulnerable population. And we're using our screening tool to really find out, the whole the whole theory about hydroxychloroquine. So we're looking at, well, how many patients who have lupus or rheumatoid arthritis that are currently treated by hydroxychloroquine are somewhat, quote, immune, and they're seniors, of course, 65 and older, from COVID. I'd say we don't have enough data to make anything significantly conclusive, but, it's fascinating that the ClickMedix tool is being used even at the research part. So I think COVID's really opened up some new opportunities, and, anything digital is seeing an upswing and uptake. I'd say it's definitely a silver lining, and we're going to learn so much from this disease and be more ready for a crisis like this in the coming years.
Wonderful. And Rebecca, you've been very much involved at Engineers Without Border in supporting pivots around PPEs in these various environments. Can you tell us more about what the work Engineers Without Border has been doing, how you've been working with different companies in developing countries, and what you've seen in the context of COVID?
Yeah, absolutely. So hi, everyone. I'm Rebecca Alcock. I'm a biomedical engineer at the University of Wisconsin, but I have been really involved in the Engineers Without Borders international response to responding to COVID. So it actually kind of started at the University of Wisconsin. We were involved in developing some open source PPE designs. We were working at the makerspace directly with the local hospital here to come up with some designs when that first initial acute shortage in the US really emerged for PPE items. And so we were working on developing those items. And after we released those designs, we kind of realized that the problem was more on the logistics side of after you release the design. What do you do then? You've got a bunch of manufacturers were approaching us saying, hey, we're ready to retool and we want to partake in the response to COVID and make some of these designs. And we had organizations in need of PPE coming to us saying, how do I get my hands on this? And so there was this disconnect between those two groups. So we worked then to develop a platform called ShieldNet that automatically does the matchmaking for us. So it takes a number of metrics into account, like order urgency, production capacity, order size, and several others to make those connections and facilitate that. And then Engineers Without Borders kind of came into the picture here to expand those efforts internationally. And we started with Guatemala because we have some really strong connections there. And the story is actually started 2 years ago. There was a volcano eruption that devastated many, and Engineers Without Borders was able to step in and help with the crisis response at that time. And a lot of great partnerships were created then 2 years ago that enabled us to act quickly now in response to COVID. So in Guatemala specifically, we have worked with a bunch of local manufacturers to enable local PPE production. When there's this global pandemic and global supply chain disruptions, the import of PPE is not going to work in a lot of places. Enabling the local manufacturing is what was really key. So we've done that, and to date we've been able to produce and distribute over 100,000 units of PPE in country with locally available materials and locally available manufacturing processes. And now we've expanded into a handful of other countries as well, including Malawi and Yemen, and we've partnered up with UNDP in order to make that happen and work through their country offices.
Great. Ting, you've been in a very unique position where you've been involved in innovation processes with large multinationals, but also innovation processes that involve government. In this kind of context of COVID, what do you see in terms of issues around scalability? You really have a proven record in terms of that. As we discussed earlier on, there's a lot of pivots going on, but companies like ClickMedix have been through this process, really can provide a lot of lessons learned to what works, what doesn't work. Please share some of your own thoughts on this.
Yeah, sure. I think one good example would be our program in South Africa. While we work for a private sector mining company, when it comes to COVID, all of the guidelines are South African guidelines. And also the network of doctors and healthcare are partly private, partly public, because, you know, patients will go wherever they need to go. And most times it also ties back into insurance schemes. Some are privately funded, some are public funded, and they get actually funneled through part of the screening process, which we initiate using our software into the care delivery in terms of a hospital or clinic, and then they are tracked there. Now, what's interesting is I think most countries does contact tracing as a public health program. So those are being done and deployed by governments. And where we're actually having a hybrid approach is for all of the Sobhani employees, they're being done by the case managers of Sobhani, a fully private effort where we have full, direct, real-time feed of their current status, which is so important for something that spreads so fast like COVID. On the other hand, within the communities, we actually submit our list of contact tracing to the government, who then does their version of contact tracing with government-owned health workers. So in this way, we're getting the best of care to employees in the fastest time possible, but we're also helping the government in terms of identifying those that need the contact tracing, and that is the role of the government to enact on and follow up on those who need to be case managed that are not employees. So I thought that was, you know, it's definitely a co-creation process to figure out, you know, while the government has this portion, the private sector has this portion, they all want the same thing. Fastest way to identify those who are suspect of COVID, fastest way to figure out how to manage them, and then making sure they have the right care and the right equipment and right medication to get better and control the spread.
And you've also done B2B in the health sector, if I'm correct,
Yes.
These kinds of partnerships. What has been your lessons learned in terms of what it means to work with large, and some examples, if you have, in terms of those kinds of collaboration with big players in the health sector?
Yeah, for sure. I mean, I'd say, you know, being able to move fast has definitely been a big advantage. Being a smaller company, you know, compared to, say, you know, large consulting firms, you know, and Sobhani is a good example. They needed something tomorrow. We were able to deliver that quickly. And a larger company just takes more time in terms of reacting, collecting requirements. We've built a platform, I'd say 10 years ago, I was literally physically stuck in Africa because I needed to make one little programming change on the application. So since then, we've tailored our technology so that an end user, like a doctor at the front line, can log in and make that change. So we don't need programmers to support full end-to-end customization or changing protocol. Something like, well, now we have to exclude all countries, you know, with the rule and the screening changes that's happening daily with COVID. So we could do that, and we empower the end users to do that. So those are at least some of the learnings that we've seen, you know, being very fast in responding, very fast to adapt and create a solution. And then the third part is, you know, understanding that contracting and the actual process, you know, security, scrutiny, all of that are just a given, takes time, have the documentations ready, and hopefully everyone moves along quickly. And I'd say I've never seen customers contract so quickly. And, you know, it's by necessity, their emergency protocols enacted. So, you know, definitely we're not getting stuck on bureaucracy. This is a public need, and also, you know, the need for everyone to be safe away from COVID crisis.
Great. And Rebecca, from your perspective, from Engineers Without Border, where you're providing assistance in these innovation processes, what are the key players in the ecosystem at a country level that you engage in this, not only for product development, but also for product surveillance or after support? What are some of them? And maybe Guatemala, I think, is where you had your sort of big success. So if you can elaborate what happened there and who were the players, it'd be very useful.
Yeah, absolutely. So there were a lot of people that we included very early on in the process to make sure that, you know, we were doing everything how it should be done in Guatemala, and contextually relevant decisions are being made. And so right from the get-go, we were able to establish a relationship with their Ministry of Health. So working with them directly throughout the process has been huge to align the needs. We also went to hospitals directly. So aligning the needs of what the Ministry of Health saw to be the problem and also what the doctors on the front lines were experiencing the problem to be, and making sure there was connection and collaboration there. And then we also, like I mentioned, partnered directly with hospitals. So we've had 12 partner hospitals in Guatemala that we've worked with throughout the process. And that was really important in prototyping these new PPE products. When we were going to these manufacturers and helping them retool their production lines, for example, we needed to test those prototypes that were coming out of there before submitting any large orders to make sure that they would be used by those doctors on the front lines. So we would create little batches first, send them out to these hospitals, get their feedback, take that back to those manufacturers, and work with them to make any design changes that needed to be made before submitting those large orders. And then we also worked with some industry associations, which was a major part of our success in Guatemala. So through our Rotary connections there, we were connected to the Plastics Association. And through that, we were able to find these manufacturers that were willing to work with us very directly to transition their production lines. A lot of them wanted to, but it was a much more intensive process to understand the regulatory environment, for example, around developing PPE, especially for a company that may have just been producing pop bottles before, or something like that. So making that change, understanding that regulatory environment, and then working with them collectively to figure out who's going to be the best players here, who's willing to share information, who's willing to go through this prototyping process. So having that industry association connection was really important. And then lastly, just having those connections to a bunch of other industries. So we've been working with the textiles industry, we've been working with the plastics industry. We're looking now at getting groups that are involved in electronics to make powered air purifying respirators. There's a bunch of different people at play, but like we've said, all throughout this process, we want to spend like 90% of the time doing the needs assessment and establishing the right partnerships up front, and then 10% of the time responding to the needs assessment. We really have to understand the problem and who are the players on the field before moving into something like that.
And Ting, I mean, from your perspective, working in India and others on this telemedicine, what are some of the, what do you think about the right regulatory environments? What is the role of different, or sort of governmental agencies and quasi-governmental agencies? And what, in order to make sure, a lot of countries are adopting these telemedicine, thinking about going to telemedicine, but it has to be done in a way that perhaps you want an innovation sandbox, but also ensure that you have, the right kinds of outcomes and relationships and quality assurance. Would like to hear your thoughts.
Yeah, for sure. I think India is a good example. Obviously, telemedicine has been done in the past, although new rules or emergency adoption of telemedicine is making it more widespread. There are definitely a few barriers. For one, there's certainly the technology and bandwidth issues, especially over India. Not everywhere has good bandwidth, so there's certainly some technology tweaks for what we call intermittent bandwidth. Sometimes you have it, sometimes you don't, and then being able to tailor to that. So, new provisions we're making would be, going from video down to audio if your bandwidth drops significantly. So there's that technology issue. And the second is the government regulations. There has been many countries that have very mature regulations on telemedicine, what makes it safe, and licensure and all of that. So there's a lot of, I would say, learning of insights among different countries in terms of telemedicine policies, and then rolling that out. And I'd say, that part it's probably one of the easier hurdles compared to the third hurdle, which is really a business model. So one example is one of the hospitals rolled out telemedicine, and the pricing was the same as an in-person visit. So on the perception of the patient side, they felt telemedicine should be lower cost because they're not getting a full physical examination. They're not seeing a person. They're not getting any, quote, perceived service. And then when they logged in, there was a long wait time, or they couldn't see the doctor, and just all of that technology fidgeting took about an hour. So it was perceived as it took longer, it wasn't as efficient, not as much could be done, which is true in a video consult. And therefore, I think a lot of what we call service packaging is needed, and also marketing communications. How do you communicate what things could be done optimally in telemedicine? I think follow-ups are great examples. You don't really have to do a physical examination. Ideally, you would, but in a follow-up, you already know the diagnosis, you're following up on potential symptoms or adverse reactions to a treatment. So I think that's a really good use case for it. Something like COVID, which has a very unique use case where one of the goals is to not overwhelm the hospital system or the healthcare system, so that someone who cannot really be serviced, for example, someone without a breathing problem, can't really be helped at the hospital besides probably taking up a bed, should try to recover elsewhere or mostly in isolation at home. So that's actually a quite unique use case that we've seen that telemedicine is really quite apt for in terms of controlling that traffic and maintaining the capacity of the healthcare system so that whoever needs the right care gets it. And I think in general, COVID has really accelerated all the problems and solutions we've seen in healthcare. Access. Now access is everybody, regardless of income. You can't go out, therefore there's no access. And then second is payment. So if you're not on a digital payment system, it actually becomes really difficult to get and pay for services. And certainly the third part is, I think before COVID, a lot of doctors thought they couldn't do their healthcare services virtually. It had to be in person. Then because of COVID, they found out, well, there's a lot they can do remotely, in terms of assessments and consultations. And I think there are also some innovation around, for example, pharmacies that have a virtual doctor consultation, or labs where a nurse will come and take your blood sample and then send it to a lab. So I think, with the crisis, there's definitely opportunities that we're seeing with many different solutions.
Great. Rebecca, I mean, people have been reading up about the wild west of PPE purchase. It's been a bit of a wild west market, all kinds of players trying to buy. I mean, only 3 to 5% of the market is being served. There was so much cottage industry of PPE productions that it meet certain quality standards. From your perspective, what have you seen in terms of what would work in a country to ensure that you have the right workflows for PPE standards and production?
That's a great question. Yeah, so we have heard many stories, unfortunately, from the country offices that we've been working with of, plane loads of PPE being imported where the quality varies significantly throughout the batch of N95 masks, for example. And so what can we do to make sure that, that we're not distributing PPE to healthcare workers that then they think they're safe and they're actually not, which can be incredibly dangerous. So the approach we're taking now is actually doing some capacity building with university partners. So the University of Wisconsin has really taken kind of the lead role in that in partnership with Engineers Without Borders. And so what we're trying to do in a lot of these new partner countries that we're working with is find universities that have been already actively engaged in the COVID response locally. And we've seen that throughout the US too. The maker movement has been incredible. The DIY movement, a lot of those groups were actually the ones who filled the PPE shortages early on before the big players were able to get producing at scale. So we're finding those groups in these partner countries, and we're working with them to develop some local testing capacity or local testing systems. And that could be an expansion of the existing regulatory body at the government level. Do they just need more capacity and therefore we can extend some of that into the university space? Or if that doesn't exist at all, how can we set up a university to be able to either test those import loads coming in or throughout the product development process? If we are adapting designs to use local materials, for example, can we set up testing with the university to make sure that there is a level of quality guaranteed? And even if it depends on the country, right? What kind of regulatory systems are already in place and what kind of processes new manufacturers have to go through in order to be certified to sell medical equipment. That changes drastically through the university. But like Ting said, we have to be very nimble here in this situation. So if the university can provide some non-biased or unbiased opinion or evaluation of these various products being put to market, that's really the approach we're taking, and we think it's working well so far, and we hope to do even more of it going forward.
It's very interesting. I'm launching on Wednesday with the Minister of Health of Turkey a global partnership with a state-owned agency So we talk about pivots of businesses, but you can also have government agency. There's a state-owned agency that deals with quality assurance of medical tourism. It's about a $2 billion per annum business in Turkey. And they pivoted, they were tasked to be in charge of the whole COVID-19 response in the country, which had four things. One is to manage the inputs coming into the country, what they needed. Secondly, quality control CE standards, in country. Of course, it's a middle income country, so it's a bit of a different sort of kettle in terms of, set operate. But it's very interesting that a state-owned enterprise, which has the nimbleness of an enterprise, but some elements of the government. I mean, they have 1 billion in 6 weeks. In 8 weeks, they were able to do quality control around 600 million PPEs, and that's why you can see these planes going to the U.S. and UK from Turkey in terms of this production. But it was very important for them to ensure there was no price gouging, but because they also were providing the inputs to the private sector, they knew what was going in, right, in some of these. So all the players in certain things were receiving the right filters. And what's interesting right now, what they're encouraging the sector here is they've been doing all these mask making machines. That's what they're getting into to enable other countries. Ting, my question to you is, from a business perspective, from a financial perspective, I mean, you have it's not clear to me whether business to government, business to consumer, business to business. What is the financial and operating model for this telemedicine work as hybrid? What works? It's a very tough sort of, I mean, it'll be interesting to hear your thoughts after all these years in the trenches pioneering this. The second related part of this question is, in India, they talk about the Jugaad approach, which is the lean, resilient approach in terms of, innovation. Do you see this coming from a resource constraint perspective where you were working in a country like India, working with the low-income? Do you see the opportunity in the US to bring this and work? Or, I mean, it'd be interesting to get your view on both of those.
Yeah. So first on the business model portion. So recall the mission we have is impacting over 1 billion people. Our business model aligns with that in terms of, it's a software as a service. We charge per user per month. And when we sell it to businesses, a user is anyone who has a login, which is likely a doctor, nurse, health worker. So it aligns in multiple ways. One is if a single nurse can service, 1,000 patients, and they're going to get some revenue from that. And therefore, our software to enable them to get to that much more reach is only a fraction of their current cost to develop that, what we call new or expanded revenue stream. So it makes sense from a B2B perspective. And then they can figure out whatever pricing it is that they then charge patients directly. Now, the only place where we actually charge per patient is when we work with population health, selling our platform to insurance companies, where their business model aligns with per member per month premiums, in which case, ours, again, it's a fraction of their revenue. And by using our system, they can deliver better care, which will increase their savings, which is the higher profit increases the profit margin for the insurance company. So in every business model, we align with our customers' revenue model, and then just put ourselves as a fraction of that, which also accounts for utilization. With telemedicine, as you know, your server and hardware software costs is proportional to utilization. And as recently, a lot of telemedicine companies are having bandwidth issues, or they didn't expect as much utilization because, when it's part of a commodity in a sense, the utilization is probably like 5-10%. And then because of COVID, increases by 50 times. So a lot of infrastructure wasn't set up for that. So we incorporate those thoughts into our business model, and therefore making it a very, what we call no-brainer business model. And essentially, if you can get one patient with our software, that's how much you pay. And so if you can break even with one patient, so there's really no question about, the pricing. And that's really what we want to do to make sure that our solution is solving a problem and that pricing is really not an issue. Mm-hmm. Now, on your second part, our innovation, we are certainly seeing a lot.
Did we just miss her?
New ideas and new products, particularly some on the diagnostic side out of India and or other countries, and we're seeing ways to help accelerate their approval, CE or FDA, and then introduce them into the US. I'd say another part of innovation, reverse innovation, that we have brought back to the US the most is actually this home care health worker approach, community health worker approach, which we're actually doing now in the US through insurance companies that, I think in the US we call it case managers or home visit nurses. So that's really leveraging all the efficiencies we saw and the cost savings that we saw by having health workers in emerging markets and applying that model in the US, which you see huge cost savings in doing that.
Great. And Rebecca, I mean, one of the exciting things about Engineers Without Borders is you're really bringing these teams of people with these different backgrounds to really come together to work. I mean, that social capital aspect, that building bridges around common solution is very unique, and there's element of altruism and other things that drives the teams. It'd be great if you tell us a little about how, some flavor of how this goes and how this works,
Yeah, absolutely. So like you said, it takes a very eclectic team to provide the sort of technical assistance that's needed to help these companies retool for PPE or whatever product it is that we're working on. So I guess on our end here at the University of Wisconsin and Engineers Without Borders, we've got a team of a handful of biomedical engineers, mechanical engineers. We've got filtration experts that we tap into. We've got textiles experts that we tap into. We've got somebody with 15 years of medical device experience in industry on our team. And we've got just a really eclectic group, like I mentioned, and people that are willing to kind of just hop on these online platforms whenever it's needed to answer questions across time zones and across disciplines. So we've certainly learned a lot too from the beginning when we started this whole effort in March. And we've been able to apply that almost directly in these new countries, obviously adapted to the specific needs of that country. So with these groups in Guatemala, for example, the Ministry of Health, the industry associations, and all of that, it just takes time, but coordinated efforts. So we developed this playbook, we call it, that kind of outlines that experience in Guatemala and how we went about the needs assessment, how we went about establishing the partnerships, who we were looking for in partners and what kind of qualities they had, and then going about the prototyping process and following all of that through to the monitoring, evaluation, and learning piece of this whole process that we can apply elsewhere. So it's looked just like a melting pot, like you alluded to, with all sorts of expertise and people willing to move nimbly in order to answer the questions as needed. But like I said, the kind of core of the program was established early on with all of the lessons learned from Guatemala, and we can apply that and adapt it to all of these new partners that we're working with, and that's really what's enabled us to act quickly. So we rely on the same experts here on our team in the US, and we tap into them, but it's all applied with contextual relevance based on the country office's needs.
Great. We can open up to the floor. This is a very new platform for me, so I don't know if Sheila, can people ask questions, and how does that work? It's a chat or oh, here, Rebel has it. There's a question for you. Can you see it if you click on chat? Do you feel inclusive business are somewhat resilient in terms of being prepared to manage risks, respond, adapt to crisis? Well, it's sort of similar to what I was just saying, this issue of when you're dealing with the low-income populations. Now with, we're actually seeing these shocking statistics where so many people are going to go under poverty. We're talking about, 30 years of, progress being reversed and a large numbers of folks going to poverty. And she just wanted to understand how's that's affecting your business and the resilience. Yes.
I think, well, from our perspective, we have been working as inclusive business, low income, women, disabled, whatever you name it, being inclusive to everyone, regardless of what we call it, income and race and gender. For us, mainly because we work indirectly with the supply chain, we're definitely seeing a lot of nonprofits that we support using this time to innovate. In fact, one of our programs, Premier Hair, which is a microfinance program, they're retooling to have their community health workers when COVID crisis is over, quote over, and the health worker can then go out and try to reach the very rural and vulnerable population that actually can't really be reached through any other means. So they're leveraging their current health worker workforce to reach those and to let them know about the pandemic and how to stop its spread and how to protect themselves. So we're definitely seeing this time as a time of innovation because, what else are you going to do? You're at home in isolation. And also, I would say new ways of being innovative and making income. So teleconsultation, as I mentioned, it's definitely having an uptake, and more and more people are using it, and therefore actually helping, women and women doctors. As you know, one of our customers is doctors, and they have a cadre of women doctors who have been doing telemedicine, and this actually has helped drive the uptake and encouraging more women to be providing services virtually. And those are just a few examples of where being inclusive business, both inclusive ourselves and helping other organizations that are also inclusive, really growing and scaling and taking on innovations.
So I think the final question I will ask, we've talked about how these digital delivery systems can be used for production or service, but in terms of learning and capacity building, let's say in the context of ClickMedix, as it relates to the doctors, and other players, from a skills development perspective, what are you seeing as the challenges in terms of usage of technology, and how has it been an enabler for them? I mean, if we're going to go digital, and a lot of these, and then in the context of, I think, Engineers Without Border, what does this mean, rather than having in-house workshops and sort of, what are the elements you see in terms of what's going to change in terms of skills development of the doctors you're working with, and in the context of your manufacturer? Go ahead.
Yeah. I say, we onboarded a number of new doctors onto telemedicine. And a lot of times they end up spending time training the patients on how to turn on their video, turn on their audio. Just like when you join this particular conference, you have to allow microphone, otherwise you see nothing. So just very, I would say, simple tech support that, new doctors are actually having to do. And it actually takes up some more time. What is helpful in terms of understanding that insight is improving on the technology part, in terms of how do we get people already set up by the time they enter a video call with a doctor. So I think that's really quite some learning. And you actually, I've seen Zoom improve. I've seen many other video software improve in terms of that self-troubleshooting layer. So that's different one where the more we learn, the more we find issues, the more we can actually improve the technology to resolve those issues that are known. I think on the second part is, for doctors, the use of digital technology, digital diagnostics devices. That's definitely needed. There are, a number of new devices out there. Some of them are still priced too high for consumers to use, but certainly is a time to adopt some of those and actually help the patients even do their own self-assessment more and more at home. We still see a lot of need for health workers, which is also an opportunity to provide the service of equipping patients, especially the senior ones, with diagnostics like a ECG or stethoscope or otoscope, to help them communicate the medical information to a remote doctor. So we certainly see there's a gap there still. And, as much as we can improve the technology, sometimes you still need a human to try to facilitate, and a human to actually express the, empathy component, to actually show that there's care, and also help us learn from a technology side things that, we didn't anticipate.
Rebecca, from your perspective?
Yeah, I'll jump in here with, I think technology has really enabled the response from Engineers Without Borders in two really major ways. So one of them is that the world is growing smaller and smaller, and even because of COVID. And we've seen that, these platforms like this, or like Zoom, or whatever platform you're using to communicate, there's so much that can be done remotely. And like Ting said, in terms of telehealth, that's very apparent. And then even just in terms of working groups and global collaboration, for companies or for nonprofits. We can do so much through these video conferences that we've been able to communicate with, our group of engineers in Yemen that we've been working with on local solutions. We can chat them throughout the day, and then they go have a meeting with the Ministry of Health, and we can get questions answered on the spot. And it's really enabled this quick interaction that we might not have been able to do before, and it's just been birthed out of necessity. And then the second one here is that this crisis has proven the need for remote mobilization of resources. So that was really what we were working to do with ShieldNet. So at the University of Wisconsin, like I mentioned very early on, is that we were connecting automatically these organizations in need of face shields to the manufacturers who are making them. There was that disconnect there because a whole bunch of manufacturers who had never been doing that before were now producing critical PPE items, and these organizations in need didn't know who to contact or who to talk to in order to get those items. So that platform allowed us to remotely facilitate these interactions that may not have otherwise occurred, and it's allowed the movement of millions and millions of shields now across the US and even internationally through that project because of technology and what we were able to do through that platform and through some of these optimization and logistics platforms.
Great. I mean, from the business call to action side, with all of these companies like ClickMedix who have this proven sort of business model, and partners like Engineers Without Border who also have had their track record, I think what we're interested in is in terms of how we can scale replication of specific health innovations across geographies, across different parts of the world, and what would be the kinds of, there's expansion strategy, but there's also this kind of technology transfer, part of it. And especially now that governments are taking this on as a very much part of their overall, sort of remit in the health sector in the next 2 years. I mean, you see the same thing in education happening. People have to pivot right now in many countries. Kids are watching on TV and radio. So you have to figure out what works, what doesn't work. Not everything has to be, digital internet delivery. But the replication agenda, what about the mechanism by which you can operate this kinds of skills transfer? And third, what is the right business model that enables companies to go to scale, but also involves the right kind of actors, as you said, in academic institutions, bigger corporates who are interested in getting these innovations. These are the things that we look forward to have a sort of follow-up discussion as part of this strategy. So I see that Sheila on the chat is also put the Badger Shield PPE matching platform. Sheila, can you also put the ClickMedix link on that? Yes. And any final thoughts and words from both of you, Rebecca and Ting? Go ahead, Ting.
I would really appreciate this opportunity. As you said earlier, how do you help innovation scale? It's exactly events like this where we're learning from each other. We are sharing our knowledge and insights, and we're trying to figure out, well, who else has the same problem and can use the same solution? And we've learned so much over the past decade on digital health, digital adoption. And really, I would say technology is the smallest of barriers. It is really in adoption, and, especially for healthcare, there's the policy layer, regulatory. So, those have now pretty much been resolved, which is great. And then I think the hardest hurdle of them all has still been that business model. And, with governments, it's that contracting process.
Right.
They are somewhat, not all of them are transparent, and therefore navigating that, how long should it take, all of that, right. And it's worth the effort to wait for years for a contract. I mean, so all of that, I think our insights, we look forward to hearing and sharing, with everyone else on the platform. So really appreciate this opportunity. And Rebecca, I've learned so much from you, and there's certainly a lot of PPE needs from other countries where we operate. I would love to get in touch, and thank you for having this event and this platform.
Great. Rebecca?
Yeah, thank you also for having me. I feel incredibly honored to even share a platform with you two that I'm talking with. I'll just say that the kind of end comments here to answer that last question you posed was just that the model that's worked for us has been open source designs. So we've really rallied around having a design that we can just transpose to whatever context. The expertise then remains constant. and you can just adapt it slightly for each context. That's been fantastic. And then also these collaborations with universities and academia. What can we do? What kind of resources can the University of Wisconsin and others like us provide? We've really mobilized to help in response to COVID-19. And I think there's a lot of potentially company and university partnerships that could come from this. And then lastly, one of the other major things for enabling local production of PPE and allowing those manufacturers locally to make that transition is mitigating the risk for them. So is there an organization that you could partner with internationally if you're a business in the global north? Is there a business that you could partner with to help mitigate that risk to make that transition for them? So that's kind of the model that has worked for us so far, and we could see being really useful going forward. And so I'd just like to thank you all again for letting me join the panel.
Thank you very much. Thank you all for your time, and have a good day or good evening, wherever you are. And thank you for participating in this event. Thank you very much. Bye.